Yep. Okay, great. All right, anyway, welcome to our monthly echo. This is our long-term care learning action network, where we are a community of learning. We'll be do confidential case sharing. Hopefully it will be very practical, and we'll be sharing practical tips, interdisciplinary, and free CME and CE. This is
Dr. Wen, we can't see your screen yet.
Oh no. Okay, let's try that again. All right, can you see my screen now?
Yes.
Okay, sorry about that. Okay, well, anyway, this is just our little collaborative page. This is our long-term care learning action network. We're really appreciative to have HIH and Mountain Pacific and United Healthcare and Aloha Care, sponsoring this whole collaborative partnership for education and sharing. And that this is a safe and confidential information. We need to keep everything HIPAA compliant and create a safe learning environment. And hopefully we'll be encouraging each other and inspiring each other to keep on going and doing the wonderful work we're doing. This is our schedule. We are going down the topic theme for the next couple of months is depression. We did recognizing depression last month, and we're going to be talking about SBAR depression and medical treatment today on the second Tuesday of each month. During this ECHO series, we'll be exploring strategies for well-being during pandemic and recovery, as well as practicing some age-friendly health system strategies, and the focus for these few months is depression. And identifying QI strategies to help us make care better and better, and increasing knowledge for the regulatory guidance for COVID and quality measures. That's why we have all of our partners here. And in order to receive CMEs, you will be, actually there'll be a link in the chat box at the end where you can go and complete an evaluation. We are approved for CMEs as well as social work CEs. Okay, and our hub team is here. This is me, Dr. Wen, I'm the course director. I'm the speaker today. Unfortunately, Gail Rodriguez cannot join us today. Something urgent came up, but Dana Mitchell's here. Say hello. There we go. And Lori Henning. Great. We have no conflicts of interest. Okay, and here we are. Being that this is National Caregiver Month, and you are all caregivers, I wanted to raise a toast for all of you, like Christopher Robin here. He's raising a toast, toast each other. Cheers. Big thank you for continuing to carry on the good work you're doing. So yes. And I wanted to start off with a quick chat waterfall, if you will, and maybe put down on the waterfall all the things some of the things you're thankful for. You can even put down the names of the colleagues you are thankful for. So I'm just going to give you a few seconds to put your chat in the chat box. And then when I say 3, 2, 1, go, hit enter, okay? Go for it. All right, 3, 2, 1, enter. Do we have anybody thankful for anything?
We do, they're coming in. So Michaela is thankful for family. Evelyn is thankful for good health and the safety of family and friends. Marie is thankful for her amazing family. And Dana for being here in Hawaii, the glorious sunshine and the wonderful people she's getting to meet. And more folks, Marcia is grateful for her family. It's a good month for that.
Yes, this is a good month for that. Okay. All right. And of course, since we're all caregivers, right, we're always thinking about our residents and what can we do to help them have an enjoyable holiday experience. The Alzheimer's Association actually sent us like a dozen tip sheets for all you guys to be able to draw upon. including ideas for activities and ways to prepare friends and families for how to visit them when they haven't seen them in a long, long time, right? They all come from the mainland, right? And it's been a long pandemic and they're finally showing up and they haven't seen grandma or grandpa in a long time. So maybe they need a little bit of preparation in advance, and also some ideas for you guys as well. So this is just from one of the holiday tips sheets, and it talks about celebrating in the most familiar setting, because changes in environment can be distressing. So holding a small family celebration at the facility may be less stressful than taking them home to be in a large gathering, which may be quite overwhelming. And you might even have them participate in the holiday activities at the facility, and also arranging for a few family members to drop in on different days instead of having them all come at once. And besides, we can't do that anyway. We have to minimize our visitors to a few at a time. So, and also maybe even providing an update, letting guests know ahead of time about any changes since their last visit a year ago or whatever it was, right? Offer communication tips, like don't criticize them for repeating themselves and telling the same story over and over again. And there's actually tips for kids and teenagers and all that kind of stuff that you can hand out to them as well. And also suggested activities for them so that they don't have to just be sitting there staring at each other. So actually all of these tip sheets are posted in our ECHO website under resources tab. So hopefully you'll be able to access them and make use of them. And yeah, so I also wanted to open this up for maybe can we share about what kind of creative things that you are all doing and all planning for the residents for Thanksgiving? Any creative ideas for creating holiday memories, for yourself, for your facility, for the residents and families, the residents' families and the residents' friends. So just gonna open that up in the chat box too, or speak up. Share about some things that you're planning to do for this Thanksgiving. Are y'all excited for Thanksgiving?
We don't have any comments in chat yet.
Uh-oh. Hopefully people are planning something.
We do have one comment. They're planning lunch with the residents.
Ah, good.
A nice lunch. That's always welcome.
So a special meal. Yeah, how are you guys gonna do visitors?
Maria shares that the plan is that they'll be eating too much.
Uh-huh. That's great. Are you gonna do Thanksgiving over one day, or is it gonna be extended over a few days? Since we can't have too many people at once. All right. Well, keep thinking about it. And of course, you can still share later on if you want to. So, okay, let's move on. And we're going to talk about Port Eeyore again. All right, so we're going to talk about SBAR, depression and medical treatment. Right. Last time, remember, we talked about how do we complete the PHQ-9 and sit as a screening tool, and doing that and sitting down with them and helping them figure out the frequency of the certain behaviors that we've been seeing. Well, what happens after that? What do we do with those PHQ-9 results? Well, the score range is from 0 to 27. If PHQ-9 is less than 5 and they don't admit to depression or suicidal thoughts, then probably just quarterly screening is fine. If their score is between 5 to 9, then they're probably in this mild range. Or if they admit to any depression or suicidal thoughts, then of course that needs to be taken quite seriously. right? And then, we go on and do, of course, any suicide intervention for anybody who mentions that. But of course, it will need a physician or provider evaluation with diagnosis and consideration for medications or site consults, and kind of stepping it up a little more on that end. And of course, always including a non-pharmacologic care plan, which includes cognitive behavioral therapy or behavioral activation, changes in the environment and in the activities, because medication is really not the only answer here. And of course, PHQ-9, another really great feature about the PHQ-9 is that can actually be used to monitor depression severity over the long course as well. So depression can be disguised. Is this a depressed Eeyore or a very tired bumblebee? I don't know. Sometimes it's not always what we think it is. And that's why the PHQ-9 is a screening test, right? There needs to be a more thorough evaluation. For example, if someone has a lack of appetite, it could be due to a medication, right? Or if they have poor sleep, maybe they're in a manic phase of bipolar disorder. Or if they have hallucinations, maybe it's delirium or medical illness even. Maybe it's medication, maybe it's psychotic depression. So could be any one of those things, right? What about thoughts of death? Well, maybe they just have a serious illness and that it is life-threatening and they're just being realistic. Or they need help with symptom management so they won't feel like they need to die, right? So there's a lot of different things. So anytime any of these items in PHQ-9 come up, these really do need to be explored a lot further. Okay, so what do we tell the doctor? Well, fortunately, we have a really great template. It's the PHQ-9, and you've already filled it out. So that makes life easier, right? And so what kinds of things might we tell the doctor? So let's see. Here's an example. Eeyore has a PHQ-9 score of 10, right? And you can see we've added up over here, right? He has a history of hypothyroidism, depression, and chronic pain. He's on Synthroid, 112 micrograms a day, and Zoloft, 25 milligrams a day. He's been looking gradually more and more depressed in the last 3 months. However, in the past 2 weeks, he feels down and depressed more than half of the days. He feels like a failure and that his friends have let his friends down half or more of the days. He has little interest in joining activities, also a little more than half of the days, and he has trouble concentrating half or more of the days. And sometimes he thinks he would be better off dead, right? And so if you look at all these, right, there's the symptom presence and the symptom frequency. What's the R, right, in SBAR? I'm worried that he might be quite depressed. Would you like to see him soon? We can also meet with the social worker and the rec therapist to review his activities care plan. Do you want to check labs or adjust his Zoloft? Have the psychiatrist maybe see him again? It's been a long time, right? So that's an example of a depression SBAR. And it's really helpful because it helps to quantify this, because later on, right, hopefully we'll be able to, if with some interventions, we'll be able to see a difference and an improvement in his scores. Okay. So I wanted to touch base a little bit about suicidal ideation. While fortunately this is not a common occurrence, when it happens, it should be taken very seriously. When should we be looking out for this? According to a study by Temkins, he looked at MDS 3.0 data for all nursing home residents in the US. This is a whole nationwide study with 15,000 nursing homes. And he looked at PHQ-9 item 1, which, if you see, is thoughts would be better off dead or hurting yourself in some way. That's the item that they were looking for to see if that would pop up. And based on this, it turns out that the most dangerous window for the suicidal ideation to happen is pretty much at the time of admission. For post-acute admissions, the highest, it was highest at the time of admission at 1.24% and declines rapidly by the time of discharge. So I guess they're feeling, uncertain and scared at that point and kind of hopeless, right? So that's the highest concern. And even for long stay admissions, also highest at the time of admission and declines significantly within 3 months. And then after about 1 year, it declines a lot, right? So, I mean, just keep your antennas up for that and just be mindful that that's the window where it's the most difficult and where you really should be watching out for it more. Risk factors include people who are older, white, unmarried, male, and higher cognitive level. Other characteristics is that folks with a PHQ-9 score of greater than 10 tend to be the ones who commit suicide or who have suicidal ideation. People with moderate to severe aggressive behaviors, higher prevalence of psychiatric conditions, having the presence of delusions, hallucinations, and other comorbidities, use of behavioral health medications, pressure ulcers, more pain, all those kinds of comorbidities. So how do we prevent nursing home suicides? Because that's ultimately, we don't want that to happen, right? So it's important to understand, like, the factors with completed suicides. Who does those? Who actually completes it? And not surprisingly, it's males with a mean age around 76, a little bit younger for the nursing home population, right? That's the younger population who are cognitively functional. So I guess it's the guys who can actually realize the state they're in and be able to concoct a plan and carry it out. And those are the people we have to worry about. And of course, the majority occurs within 12 months of admission. And how do they do it? They do it by hanging, falling from heights. That is, they go to top of the stairs, or they go to a balcony or out the window or something like that. There's also cutting, asphyxiation, drowning, and overdose. When I was in Boston, we actually had an elderly woman who just put her head in a plastic bag, and then that was it. Nobody recognized or realized what was happening until it was too late. And so plastic bags are also, fair game for this. And who are the people who do it? People with physical health that's declining and people with a history of depression. But just drilling down into the depression part here, this is the one I wanted to highlight, right? Is that 62.5% of residents with a diagnosis of depression not receiving any pharmacologic treatment at the time of death. That's a lot of people. And I think this is the point where, it's treatable, it's preventable. And interestingly, also, majority had no prior suicidal behaviors or attempts in the past. So they're very sneaky and hard to catch. But I think the important thing is just being aware and being on the lookout. So how can we prevent it? Well, I think if we, try to make sure that there are really no escape routes out there for them and they have no access to sharp objects and ropes and plastic bags and all those types of things, as best as we can help it, just especially for people who are depressed or with these risk factors. And then, of course, making sure that people who are at risk receive antidepressants or medical treatment as soon as we can. Okay. And then, of course, who helps to manage this is the entire team, right? It's not just the doctor throwing antidepressants at them. That's not enough, right? There's got to be this interaction between the doctor and the patient and the team, the healthcare team, along communicating with the doctor as well. So really has to be the entire team. Considering psych consult as well as considering antidepressants, whether either of them are needed, and also what kinds of ideas we have for the non-pharmacologic therapy. And activities are really important here, and including them activities. And I just want to read a little thing here from Eeyore, right? Even though he's basically clinically depressed, he still gets invited to participate in adventures and shenanigans with all of his friends. And they never expect him to pretend to feel happy. They just love him anyway, and they never leave him behind, and they never ask him to change. So I think that's a really great model for us as well. So we can be like Pooh's team. Okay, so I'm sure you've heard about all of these types of antidepressants. There are many classes of antidepressants, kind of like a lot of different flavors of ice cream. And actually these are all chemically different. These are all in chemically different classes. And individualized selection is based on diagnosis, patient characteristics, and side effects. And so to help choose, the doctor is going to want to know about things like sleep and appetite and anxiety, or agitation, or things like that. So those are the types of things which help us decide which flavor to choose. But the other caveat I want to mention is that antidepressants work very slowly. So we have to be patient and not give up. It may take a good 4 to 6 weeks to see a good response. And so, of course, in the meantime, you can't do nothing. And so really, the big thing you're doing is making a big push with the non-pharmacologic strategies. And we'll talk about that in more detail next month. But because it takes so long for these antidepressants to really kick in, we do have to give it a good, 2 to 4 weeks at least. And then if that has passed, maybe you need to start bumping up the antidepressants. And even if longer, if there's no response in 4 to 8 weeks, consider switching or even adding different antidepressants to the regimen. So, but let's not give up, right? Because it is very treatable. And just because they don't respond to one flavor doesn't mean they might not respond to the other one or both combined. Depends on, and everybody has a very different situation. So, but we need to persist until we can get them to feel better. But all medications have side effects and drug interactions. So we have to monitor them closely. So, within a week, actually, within a week or two, we should be seeing kinds of side effects like, being too sleepy, or they're more confused and more anxious and more agitated and upset. They could be paradoxically more depressed, actually, and, more tearful, or they may be dizzy, having falls, or, decreased appetite, all kinds of things that we really need to monitor carefully, because if they're not tolerating it, then maybe it's time to change the dose or switch it. And then, of course, as we're waiting for that 2 to 4 to 8 week period, we have to think about monitoring that PHQ-9 monthly or quarterly, kind of depending on how they're responding, to see that we're really being able to maximize that. And I also just wanted to throw in a word about what about behaviors in residents with dementia, right? I'm sure you've seen that, resistive to care, combative, screaming, cursing, irritable. Some people think that's not depression, right? Because they're not crying and they're not withdrawn and they're just beating you up, beating all the caregivers up. But actually, this could be depression in disguise. So, and the usual approach is, oh my gosh, they're agitated, get them a benzo, or something like that. Give them medication, calm them down. But I think the first thing to do really is to change your approach first. And because that is the least dangerous thing to do, and the most lasting intervention that you can give consistently. So, if the approach and the environmental changes and the activities, interventions are not sufficient, then medications may be helpful. So what about these combative behaviors? Should we use antidepressants or antipsychotics? So, there was a study done by Huang, which looked at behavioral symptoms, and they said, oh, let's try antidepressants and compare them to antipsychotics. And it turns out that they help just as much. They're just both as good, except the antidepressants don't have the black box warning that the antipsychotics do, and they don't have all the other, potential problems for EPS side effects and stiffness and all that, risk for stroke or cardiac events or anything like that. So antidepressants by far are the preferred method to treat these agitated, irritable folks. And so these types of behaviors in residents with dementia can be treated with antidepressants, and they do work, right? So this flavor works for him. Okay, so what else? So the PHQ-9 can also help us follow up on depression severity, right? And so we just do this again after we've tried that medication for the last 3 months and see what happens, right? So it can serve as feedback for the team to modify the care plan. So if we look, 3 months later, right, we can look at that and say, oh my goodness, 1, 2, 4 out of 10, and ER is doing better with all these interventions and stuff. And maybe we bumped up the trazodone or whatever it was. So yeah, so that's all I wanted to say about the treatment of depression and management. And I just wanted to kind of pause here for a few questions if you had any. And I just also wanted to say, see, these guys are celebrating Thanksgiving, right? Thanks for caring. So any questions, folks, on any of the things we've covered yet so far? I'm happy to answer questions.
I'm just going to say I love the approach that they wrote there about Eeyore and his support team, his friends, and how that regardless of his situation, that they just always approached him with consistency and love and extended that invitation and then just enjoyed him where he was at in that moment. I think that's such a great message.
Yeah, we can learn a lot from Winnie the Pooh. All right, well, if you guys, you can keep thinking about it, keep thinking about any questions or thoughts, maybe about antidepressants or about suicide or whatever it is, and I'm happy to answer any of those. Just chat it in the box. I'm gonna have, in the meantime, I will have Dana Mitchell jump in to talk a little bit about quality improvement strategies here.
Hey, thanks. Can you hear me okay?
Yep.
Okay. So I thought we had talked about the quality measure for depression last time. And I thought since we're still on this topic, of course, we're focused on our residents, but it's so important to also, I think, take care of ourselves. And so I wanted to talk a little bit about that. And I did sort of wrap a QI lesson in there as well. And so I thought one of the things that I think is so important nowadays is the stigma around mental health, and especially for caregivers. And it's been such a trying year. I think that we're not super shy about talking about that currently, but it is always nice to have a reminder. And I don't know if you all followed the Olympics, but I love them. And I figure if Simone Biles can ask for help, then maybe I can too, on the national stage, no less. So I appreciate when people who are in the public eye are open about their struggles. So next slide, please. So yeah, so we're focusing on our residents, but what about us? It's no question, this is all preaching to the choir. I know that we have been really, really stressed the last couple of years, and depressed and anxious. And so many reasons for that, that we're constantly getting new guidance. What we're supposed to do changes. What we're supposed to do isn't clear. What we're supposed to do, the state says we're supposed to do one thing. CMS says we're supposed to do another thing. CDC says we're supposed to do another thing. Ombudsman comes in and says, we want you to do this. It's very difficult. We're all concerned. We're caregivers, so we're concerned for everybody's well-being. Some of us are working really long hours now. We know that healthcare in general, and I think long-term care specifically, has is in the midst of a serious, substantial staffing crisis. So people who are covering those hours, the death of residents that we've grown to know and love. It's often like losing a family member. Like I said, stigma. I think for a while there, I feel like, and this is just my opinion, that it was more so last year before Delta hit. And then I think we quickly realized, I mean, not that there should have been a stigma of getting COVID anyway, but we quickly realized when Delta went that, there was nobody was at fault for getting sick, or asking for help. I think, not that I'm going to go political, but the politicization of the pandemic and the response to it has people really stressed, whichever side you fall, or it's not really one or two sides, it's an entire spectrum. It's been interesting for all of us. New mandates, on and on and on. Next slide. Again, preaching to the choir, but I think it always helps to be reminded that that we can help ourselves. And this, I think you can start your own PDSA here on yourself. You get enough sleep. Are you doing any kind of physical activity and not beating yourself up over it? I should have added and rest, because whatever you need in that moment is what you should provide for yourself. I think we get hit all over, well, you're not exercising enough. Well, maybe that's not what does it for you. Maybe what you really need is rest, paying attention to what you need and doing that for yourself. I am amazed at how far gratitude goes towards changing an outlook. Can it cure depression? I don't know, but it seems to work some sort of a magic if you practice that on a regular basis. Finding someone you trust to speak with, someone who can be open and non-judgmental, focusing on people who lift you up. I found that curating social media, and this kind of goes back, I think, to the politicization of the pandemic, but also in general, if you're following people or you have friends on Facebook, or you're following people on Instagram or wherever you do your social media, that when you see their posts you feel bad, don't follow them anymore. whatever the reason was for you following them to begin with, put them on pause for a bit. You can always go back and follow them again, but we spend so much time, a lot of us, on our social media, because it does also feel like an escape from our everyday. But if we're not careful about what we're looking at, it can make you feel bad. So I made a focused effort to go find positive accounts to follow and things like that, that I figured, why would I go on social media if I just feel bad after I look at it? And then, like I said, try personal PDSA. So this says most people feel guilty, and I talked about this a little bit, when you're talking about goals, because we set unreasonable or unworkable goals and then we beat ourselves up over it if we don't meet it. But if you do a little tiny PDSA, it can be workable if it's something that is in your control. You're not worrying about anybody else's input or anybody else's work to help you do this. So focus on something you can control, whether it's what time you go to bed, whether it's one piece of food that you eat in a day that's better for you, whether it's curating your social media. Pick something you can control. Make sure it's something that's manageable, do it in tiny little bite-sized chunks. I am terrible about saying I'm starting my big time workout regimen next week, and something happens and it gets off track, and I am like, oh, I'm so bad, I'm terrible. So maybe it's just, I'm going to work, go for a walk 30 minutes once a week, whatever it is. It's something that you're manageable, that you can do, something that's realistic for you. And something that's measurable. So if you say I'm going to walk 30 minutes on Wednesdays, if Wednesday comes around and you didn't do it, that's measurable. And if something goes wrong, here's a PDSA part. Adopt, what can I learn from this? Instead of judging yourself. So, PDSA is you plan out what you're going to do it. Then you look back and say, did that work for me or didn't it work for me? And how do I do it again? And I think maybe our lives are full of little PDSAs that we do on ourselves that can translate also to what you're doing with your residents or loved ones. Don't judge yourself. that's obviously a big one. I think next slide, maybe I'll speak to this. Yeah, mental health matters. So I can't tell you how many, stories I've heard of people's traumatic birth experiences or their appendectomy surgeries or whatever. We're so open about talking to fairly personal health matters, but mental health still has a stigma to it. And so I'll share my story. I live in Alaska. I think in Alaska, we're very comfortable talking about seasonal affective disorder. And as I reflect on that, I think part of that is because that's something that's outside. You can't blame yourself. It's not a personal failing when you talk about seasonal affective disorder, because we have dark days. It's easier to talk about that. So we're very comfortable talking about that. I get my little light out every winter, my little desk light, and try to get outside, but if it's too cold, I won't go. So I'm fairly comfortable with that. But then I had my son, who I had 10 years after I had my daughter, and I was fairly old. I was definitely a geriatric pregnancy when I had my son. And it was a whole different ballgame with him. And I found when he was a toddler, probably entering maybe preschool, that I was so irritable with him. I would yell at him like I never yelled at my daughter. I was short with everybody. I would just have a super short fuse. And it was like, what? I would do what is wrong with me? And it finally occurred to me, I think maybe it's depression. This is how it's demonstrating itself with me. And so I sought out therapy. I have a wonderful therapist. I love her. It turned around fairly quickly for me, which I know isn't true for everybody. But I tend to take the opportunity anytime I can to say, find yourself a therapist that you like, because it's wonderful. I look forward to the chances I get to talk to her. And I don't feel like there's anything wrong with that. So, in doing my little part to end the stigma, that's my story. And I just encourage everybody to pay attention to yourselves. We hear that over and over again, so I'm saying it again. But these are very challenging times we're living in. Don't forget, we're all living through a trauma together collectively. And let's support each other and support ourselves. So. Yeah, no, yeah, we don't need to allow difficult time be harder to handle. And we are all living through excruciatingly difficult times right now. And so let's talk about them. Take care of yourselves. Thanks.
Great.
Do your PDSAs. See how I did that?
Never thought of it
Worked
before,
that right
but I
in.
think I will now. I'll figure out how to
Well,
do
and I think maybe when you do, it might take that, again, that personal tendency to judge yourself or beat yourself up if you fail. Maybe that'll remove that a step, and you can look at yourself a little bit more analytically while you're in the middle of your emotional crises, or you're just your state.
Great, thanks. All right, so let's see. Maybe we'll let Lori go ahead and talk about some important things which we just need to know about. And if we have time at the end, we'll open it up again for sharing. Okay, go ahead, Lori.
Okay, great.
I'm
So
stop
I'm gonna
sharing.
try. Okay, perfect. And I will attempt to share my screen. Can you see that?
Yep.
If I can get it going. Okay, great. So as Dana was talking about, one of those things, hit us again last week, that the ever coming changes over the last 2 years. You're exactly right. We have had so many changes that we have had to scramble and respond to, make new policies and procedures, and just, our staff and our leadership has done an incredible job just keeping up. It's been overwhelming. And so again, last week, we had some more changes coming at us. So I just wanted to review them real quick with you, kind of give a brief overview. So November 4th, last week, was a big day. both CMS and Osha released requirements related to COVID-19 vaccinations. And so we're going to walk through each of these. So first one, the CMS Omnibus COVID-19 Healthcare Staff Vaccination Interim Final Rule. That is a mouthful. So basically, if facilities are regulated by the Medicare Conditions of Participation or the COPs, then they are required to comply with this rule. And you can see a list of all the entities that are impacted by the rule here. So going forward, we're going to refer to all of these as facilities. So for long-term care, which includes nursing facilities, as well as hospice agencies and home health agencies, they all fall under this rule. And in addition to preempting state and local law, CMS says that its rule takes priority above other federal vaccination requirements. So again, healthcare institutions really need to pay attention to this one and follow it. So who's not impacted by this rule? Assisted living facilities, group homes, home and community-based services, and physicians' offices. So again, because they don't fall under Medicare's conditions of participation, they do not have to comply with this rule. So CMS did host a webinar last week, and they specified that if, for example, you have a nurse who's both working in a nursing facility and an assisted living facility, does that employee fall under the rule? Yes, they do, because they are employed by a nursing facility, so they have to be in compliance. Okay, so what do facilities have to do? There are 2 deadlines to be in compliance with this rule. Phase 1 is that all facilities must have a process or plan for the following: for vaccinating all eligible staff, providing exemptions for those who are deemed exempt, medical or religious exemptions, and for tracking and documenting staff vaccinations. So in addition to that, all eligible staff must have received the first dose of Pfizer or Moderna, or the one dose of the Johnson & Johnson vaccine by December 5th, 2021. So all those things have to happen by December 5th. Phase 2 requires that the primary vaccination series has been completed and that staff are fully vaccinated by January 4th, 2022. And this applies to the initial doses of the vaccine. It does not include the booster. And then CMS considers the definition of fully vaccinated to be completing the 2-dose regimen or the 1 dose of J&J. And it does not include that 14-day waiting period after the final dose. So as soon as employees have that second dose, they are considered in compliance with this rule. Okay, so when they're talking about eligible staff, who is considered to be eligible staff? So these are your current employees and the new ones going forward who work at a facility regardless of patient contact. So it applies to all facility employees, all licensed practitioners, students, trainees, volunteers, and contracted staff coming into the facilities. And the thing that stands out with the CMS rule is that there is no testing alternative to being vaccinated. And then I'm sure it's a relief to many of our facilities, but there are no new data reporting requirements for facilities with this new rule. So that's a positive thing. Surveyors are going to be checking to see that facilities are in compliance with this rule, and they'll do it through the recertification surveys and also through complaint surveys. And then as far as enforcement measures, if a facility is found out of compliance, the surveyors will cite the facility, and if they don't come back into compliance within the designated time frame, CMS is going to move forward with other enforcement remedies. So that includes potentially civil monetary penalties, denial of payment, and as a very last resort, termination from the Medicare and Medicaid program. CMS has been really clear on their calls that they do not want to get to these measures, and they do not want to terminate anyone from Medicare and Medicaid program at all. So they're going to do everything that they can to provide the tools needed to work with your staff to come into compliance for this rule. So on this slide, you'll see a couple of references. The first link is to the rule in the Federal Register. It's pretty long. And then there's a link to an FAQ document, which is very helpful. And I wanted to let you know, CMS is having another call on this subject on November 10th, tomorrow at 10:30 a.m. our time, if you'd like to hear directly from them. They do have some slides that you can download and more information coming. Okay, so we've looked at CMS. Let's take a look at OSHA. So this is OSHA's rule, the COVID-19 Healthcare Emergency Temporary Standard, or the ETS. So as we all know, this was also released on November 4th, and it became effective on November 5th once it was published. So since then, a federal court of appeals temporarily blocked the new rule, and the White House issued a statement saying that impacted companies should abide by the new vaccine mandate while this plays out in court. So again, we're going to take a look at what's going on here. So this rule applies to private employers with 100 or more employees. And of those employers, the exceptions are for employees who do not report to a workplace where other individuals are present, employees who work from home full-time, or who work exclusively outdoors. And I don't mean that those are full-time employees, they just exclusively work from home or exclusively work outdoors. So the requirements for the OSHA rule is that employers have to develop, implement, and enforce a mandatory vaccination policy. They have to keep records of each employee's vaccination status and then allow reasonable time to get vaccinated and reasonable paid sick leave to recover if they experience any side effects. Employees have to report if they test positive for COVID-19, and then the employer is responsible to remove them from the workplace until return to work criteria is met. And then individuals who are not fully vaccinated have to wear a mask indoors and also when they're in a car with somebody else for work purposes. So, and then as you'd imagine, the employers have to share information on the ETS with employees and also their own policies and procedures for the workplace so that everybody knows what is going on and how to stay in compliance. We have the same compliance dates for both CMS and OSHA. So with the ETS, employers need to be in compliance with all the requirements we just went over by December 5th, 2021. And then by January 4th of 2022, the employees need to be fully vaccinated or undergo weekly testing. And so just one thing that stands out with the ETS, they specifically state that employers are not required to pay for testing. And then on this slide, I have a link for you to the final rule for the OSHA ETS. And then the second link is a wealth of information on the ETS, and it includes all sorts of good information, including fact sheets and FAQs. So that's a brief rundown. We're going to continue to watch as things progress toward these deadline dates for compliance with both rules. But again, our healthcare facilities are going to fall under the CMS rule as that takes precedence. And so I know that's a lot to take in, so I'm just going to pause for a second and see if there's any questions that have come in.
Hey, Lori, I just wanted to comment that I've got a draft of a potential policy that people could use as a template. I know that I think ACA will be putting one out. I'm not sure about leading age. But also today, I'm not sure if they released it today or if it released yesterday, the EEOC has actually published the policy that they're going to use for the form they're going to use for religious exemption requests. And safeworkplace.org, I believe that's what it is. I'll see if I can find the link, has got examples, templates of forms for both the medical exemption and the religious exemption. It looks like the medical exemption is going to be really difficult for people to get. But religious exemption, I'm hearing a lot of talk about how people plan on implementing that, and I'm sure you are too. But there are some good resources beginning to pop up in response to those. So that's nice. And I'd be happy to send the draft to you, Lori. I sent it to the Alaska Health Association representative as well, just for comments and input if that's something that folks might find helpful.
That would be great. Thank you. Those are excellent resources too. Thank you for that. Okay. if there's nothing else,
Yeah.
okay,
Great.
I'm going to move on. Are we ready? We're going to talk a little bit about COVID-19 real quick and go over our data. So, so I just wanted to highlight where we're at in Hawaii with our data currently. And so we're going in the right direction, bottom line. So our total confirmed COVID-19 patients in hospital beds continue on a downward trend across the state. Everything is continuing on a downward trend. So I'm happy to be able to report that today. Our ICU bed usage for COVID patients is down. It keeps going down. So this is good news. And then new COVID admissions to hospitals, again, we're headed down. So this is good. And then for the week of October 31st through November 6th, Hawaii had the second lowest infection rate in the nation. And we were in the same position the prior week. And then for the entire duration of the pandemic, and again, they define that, these slides come from the CDC, they define that as March 7th, 2020 through November 6th, 2021. Hawaii has had the lowest infection rate in the nation. And here's where we jump a little. For the week of October 31st through November 6th, Hawaii had the 27th lowest death rate in the nation. And that is up. In the previous week, we were in the number 7 spot. However, for the entire duration of the pandemic, again, March 7th, 2020 through November 6th, 2021, Hawaii has had the second lowest death rate in the nation, second only to Vermont. And Hawaii's infection rate per 100,000 individuals decreased last week. We're at 48.5, and that's down from 58.3 the prior week. So that is encouraging. So again, overall, headed in the right direction. And we just want to keep seeing those numbers keep going down. Okay, I'm going to stop sharing my screen now so that you can take it back.
Hey, great. Yeah, so thanks everybody for all your presentations, and I'm just gonna open it up to the floor, see if anybody has any comments or questions or experiences that they've had regarding any of these topics, actually. And if there's just anything you want to share. Anybody come up with more ideas for Thanksgiving celebrations at your facilities? Or ideas that you're giving your families?
I've always thought one of the great things is in the facility setting, all the decorations that are up, because that really sets the tone and sets the mood. So I've always enjoyed that.
Mm-hmm. Yeah. Nothing? Oh, everybody's shy. Yeah. But we do have just a couple minutes left. So just a reminder that if you want to get CME or CE credits, please click on the link in the chat box. And that will take you to an evaluation form. And when you complete that, you can get your certificates. And if you have any other ideas for us to make this series more useful or helpful, what you would like to see, please let us know. All right. Thank you so much. And we'll see you again next month. Okay, bye.